I should open by thanking Shirley. Shirley Anastasi developed this talk for me, and so thank you, Shirley. Let's start. Now, look, there's a lot going on in mental health. If you think PIR is busy, the whole framework around mental health, both in the state and the Commonwealth, just rolls on. And it's quite interesting. Mental health, not only are we involved in the general health reforms, we actually have our own health reforms. So look, the first thing to come out of the National Health Agenda was the commencement of hospital boards. Queensland, as you probably all know, goes through phases. So 20 years ago, we had 52 hospital boards. That then became 13 health regions, and they then went from a fairly decentralised role to a very centralised role, and now they're decentralising again. So if you hang around health long enough, as I have, you see the whole world change. So Metro North is a combination of the Royal Brisbane, Prince Charles, Caboolture, Redcliffe and Kilcoy hospitals. We're the largest of the health services in the state. We've got an independent board and a $2.2 billion budget. Now, then with the change of government, the Liberal National Party brought in their blueprint for better health care, and the board has decided that redesign of the health system, if we're going to remain sustainable, is probably the area we're moving towards. You can read here, Metro North exemplifies compassionate, innovative and high-quality healthcare provided across one hospital and healthcare service. And one of the big changes they announced 2 years ago was the move to what are called clinical streams. And I'll tell you more about the clinical streams in a minute, but essentially there are 4 surgical departments, there's 4 medical departments, there's 3 mental health services and an alcohol and drug service. And essentially they all operate in the silos of the hospitals, and it means that, for example, one part, Redcliffe, for example, may not have a waiting list for a certain surgical procedure. Royal Brisbane might have a year-long waiting list, but there was no way of coordinating that. So the whole idea about having a centralised system that allocates people where the services are provided in a timely manner is one of the big reasons we're moving towards clinical streams. And as of the 1st of September 2013, we are now Metro North Mental Health, and currently, we are the first of the streams. And the other streams cover, mental health and oral health have started. Cancer will get up and running fairly soon. Critical care, which is ICU and emergency departments. There's medicine, surgio, heart, lung, women's and newborns, and clearly medical imaging. Effectively, the mental health stream covers the Royal Brisbane, Redcliffe and subacute, and the Prince Charles and Caboolture hospitals, each of which will also have an executive leader person in place, but probably will only have that person in place for about 2 or 3 years. In the end, the way clinical streaming works is Royal Brisbane, Prince Charles, Caboolture and Redcliffe essentially become hotels. And they don't hold the budget, people like myself will. And there's also executive directors of clinical services and in professional leads covering nursing, medicine and allied health. Now, the other big thing that's happening within the national and state context is there is a move to try and reform the way health is funded. Now, this started under the previous government. We're not sure that this will survive. The current Liberal government in Canberra has sort of said that they may or may not stay with what's called activity-based funding. But essentially, activity-based funding gives you a set amount of money for a particular procedure. It works incredibly well for a procedure like a hip or cataracts and stuff like that. Doesn't work quite so well for mental health. And again, the beauty of activity-based funding is it gives everybody a common price to work for. And there's this price called the national efficient price for everything. So there's a national efficient price for cataracts, there's a national efficient price. And if you can meet the national efficient price, you get more money. If you are more expensive, you then lose money. And if you are below the national efficient price, well, you might even make a profit, though in health that's increasingly very difficult. So the idea of ABF is health services need to be able to define, classify, count and cost their services in a way, and this is a challenge for mental health services where most of our inpatients stay for 2 or 3 weeks. But currently there's a lot of work going on. So they're trying to do an activity-based funding formula nationally. Nowhere else in the world has ever been able to pull it off. So why Australia deludes itself in thinking we will be able to pull it off, I'm not sure, but they still seem to continue to try to do it. IPA, which is the Independent Pricing Health Authority, is actually doing an activity-based funding, and our services in Metro North are actively involved in that. Queensland, bless their little cotton socks, has introduced an activity-based funding for our community-based services next year, and they're calling that packages of care. So every time, for years they've been, one of the things, if you talk to your colleagues in the public mental health services, we've got this antiquated information system called SIMA, or as some of my staff call it, SIMHA. And basically, every time you see a patient, you're supposed to put in what's called a POS, you've got to put in a diagnosis, you've got to put in a case review, and you've got to do an outcomes. Now, it sounds very simple that you've got to do that every 3 months, but most of it's quite clunky, the system, and to get the data in is quite difficult. But as of next year, if you don't enter those 4 bits of data for every patient, we won't get paid and our staff may not have a job. So there's lots of interest in that one. And we're in a year of parallel funding where they're not taking money off us this year, but they could well next year. The other thing to say is we've just been involved in, because of the clunky SIMHA system that we've got, staff tend not to put the information in, hence one of the reasons they're moving into it. But if you look in our activity system, the average mental health worker in Queensland, and I'm not knocking our staff here because this is blatantly inaccurate, but if you look in SIMA, how much staff somebody who works for us full-time and doing a 38-hour week, we can probably demonstrate between 8 and 12 hours direct clinical patient care. So to get around that, they did a time and motion study. So they actually paid some very highly paid consultants to follow our staff around and see what they were doing. And the consultants have been very complimentary. They've sort of said they can't believe just how busy mental health staff are. They'll be doing 5 things at the once. They'll be talking on the phone to a patient. They'll be entering data into SIMA, etc. But it's just, so that's been quite interesting to actually see that, when they follow our staff around, they can demonstrate that at least 30 of their 38 hours a week is involved in direct clinical care. Part of the problem of having to justify what you do is, if we can only justify from SIMA that most of our staff are doing 8 or 10 hours work a week, and we go to Treasury and say Queensland needs another 600 community mental health staff, they go, well, couldn't you make your current staff work 2 or 3 times as hard? They'll still only hit 24 hours. So it's that sort of cynical view of the world that we're trying to deal with. So looking at where the mental health stream is going, we've been in existence since the 1st of September. We're the first to be given a budget, and we've got all the HR delegations, and we've been working towards this. We first heard we were going to become a stream about 2 years ago, but things move very slowly in the public mental health area. People say, what are the advantages of a stream? And one of the advantages of a stream is that resource allocation across the parts of the stream vary, and generally the further you get north, the less the resources. So we're into as many ways as we can supporting the northern end. So Caboolture and Redcliffe we're talking about here. For example, on the after hours medical roster at Royal Brisbane, we've probably got 25 doctors. Prince Charles has 17 and Caboolture has 13. So one of the things we've started doing is now every second weekend up at Caboolture and Redcliffe, a Royal Brisbane registrar and a Prince Charles registrar are rostered on to work at Caboolture. So, and we also have given one of the Royal Brisbane registrars lives up that way, and she's more than happy to be on the Caboolture roster. So Caboolture now has it may not sound much, but working 1 in 13 to working 1 in 16 makes a big difference to people's work conditions. So those are the sorts of advantages which I think we can achieve over time as a stream. We've had external reviews of the mental health service and the drug and alcohol service. And as I said earlier, one of the moves, and it will be a gradual move, is about consistency of services and not having as much variation across the health service. And it's not just in the mental health service where there are variations. So look, some facts about Metro North Mental Health, of which I'm the Executive Director. Metro North covers a population of in excess of 900,000 people. We've got a budget of 152 million. We've got over 1,000 staff, and we provide services from birth ultimately right through to death. So we've got perinatal services, we've got child and adolescent. We look after older people. We've got inpatient and community services. We've got a large inner city homeless team, which also covers the south side of the river. We've also got a range of specialist services from consultation liaison, and these are the people that see people in all the hospitals. We've got the statewide forensic service. We've got an alcohol and drug service. We've also got an eating disorder service, of which a quarter of the staff is sitting up in the back row there. Hi, Elaine. And we also have a lot of beds. We've got 179 acute beds. We've got a 12-bed adolescent unit, which is full all the time. We've got 39 secure mental health rehabilitation beds. We have 60 community care beds. We've got 24 long-stay psychogeriatric beds, which are really nursing home beds, which are now at Coimbra. And there are 16 statewide drug and alcohol beds called HADs at Royal Brisbane. And we've got community mental health services distributed right across the district or the health service. In terms of it, the mental health stream has a single point accountability. That's me. I can get shot at any time for anything, it would appear. It's made up of 4 mental health services, and we're trying to very much to keep the catchment area mental health services going around Royal Brisbane, Prince Charles and Caboolture, and there is then a service-wide alcohol and drug service. And one of the things we've found, for example, in the drug and alcohol service is there were no consultation liaison drug and alcohol nurses at Redcliffe and Caboolture. So despite the fact that, our staffing declined slightly last year, that's the polite way of putting it, the drug and alcohol service at Biala were able to relocate 2 nursing positions. So that for the first time there's a drug and alcohol CNC both at Caboolture Hospital and Redcliffe Hospital. So that's just another, I guess, evidence of, as streaming comes about, the sorts of things we're able to do. And we've also got a series of already service-wide teams, such as the perinatal service, the resource service, and we've got recovery and support services. We've already got a number of stream positions. We've appointed professional leads for both medicine, nursing and allied health. We've got our own business manager. We've got our manager of clinical governance here. And we've got a range of team leaders covering resource, recovery, perinatal, and there's a mental health information manager. In terms of high-level governance, we've got a series of people, as we've appointed. We also have a growing range of data. We're very lucky with our mental health information manager, Ben Chappell. He's come up with a variety of performance measures that sort of pull data out of antiquated Queensland health systems, but gives it to us within 3 weeks, for which we can drill down to both service-wide performance, going down to, and I'll show you some of this. Oh, actually, no, I won't get to that. I'll get to that in a minute. So before I finish, this gives you some idea of our mental health service. And I might just sit here and show you some of it. We've maintained here the 3 catchment area services. So there's the Royal Brisbane and Prince Charles. There are a series of service-wide teams. So we've got the victim support service, we've got the mental health collaborative, we've got the clinical cluster, and those are now in place. Drug and alcohol are here, and that means ultimately, even though we can't do it yet, HADS currently sits within Royal Brisbane, that's the inpatient unit. It will go into, just be one alcohol and drug stream. And then we also have a very active clinical research structure as well. And I think last year we had about over 80 publications in peer-reviewed journals. So what are the strategic priorities for Metro North Mental Health? Now, I'm not going to read this, I'll assume you can read it. But look, it's about providing safe and effective care. It's about brief interventions and making sure that we have acute admissions that are able to deal with crises and clearly reduce admissions. In collaboration with other streams, it's to link in with as much as possible. I think there's increasing recognition that mental health services are but part of a bigger picture. We need you guys, the NGOs, to sort of work with us. Clearly, we're going to support recovery. We will continue to support our statewide services, which are listed there. We also want to make sure that we've got quality and consistency. We've got to use best practice human resource management to, I guess, recruit, develop and sustain our workforce. One of the best people say, why do I bother putting money into clinical research? One of the reasons you do it are, even though it might chew up 2 or 3 million out of 150 million, it actually shows that if you actually start to do clinical research, you not only attract better staff, you actually keep them. And by getting better staff and keeping them, you actually provide better care for your patients. And clearly, we need to continue to support and develop a culture of evaluation and quality improvement. We, for example, are KPI very rich. And that's what I was getting to before. So we actually have a consultant dashboard, and that should be on the next slide. So this will once again give you some idea of the sort of information we have. So we can measure 1 to 7 day follow-up. So that's essentially everybody who leaves hospital, we try to see them within 7 days. Now people might say that should be 100%. The issue is if you've got a homeless team and stuff like that, it's very hard to follow everybody up. There's also people go back, Royal Brisbane being the centre of the universe, we get everybody on a Saturday night down the valley and they come from everywhere, and the most important thing you learn is if the police approach you on a Saturday night in the valley and you've been charged with some drunken disorderly, you drop the S word and you say, oh look, I think I'm suicidal. That not only gets them to drop the charges, but you actually end up in Royal Brisbane. And we then discharge you the following day. And it's amazing the number of people on a Sunday morning who can't remember, they remember reaching the valley, they can't remember what happened or why they woke up in the Royal Brisbane Psychiatric Emergency Centre. So some of these people do not want to be followed up. So that explains why some of the targets are low. But we measure things like 28-day readmission rates. And, it's quite interesting. If you look at in the public mental health service, it should be around probably 12 to 14%. Some months we're up at around 16 or 17%. And the main reason for that is some Friday afternoons when we don't have beds, we actually have to discharge people early and some of them bounce. But that's unfortunately one of the mechanisms we have to use until we get a step up, step down facility that's a hint. But, these are the sorts of things that will help us reduce those. And clearly, we have the number of people with a GP, because a lot of as people are probably aware, most of our people have schizophrenia, and people with schizophrenia have the same comorbid health problems as the Indigenous community, and they die 20 years younger, usually of obesity, heart disease, stroke, you name it, because the majority unfortunately still smoke. We also measure discharge summaries. One of the major issues of if you discharge somebody to hospital, it's good to get a report out to the people that are going to be doing the caring later on. And I'll just show you some of the other ones that we sort of look at there. There's outcome measures, there's contact hours. The contact hours have to do with what I was saying before, that, we try to get, or the state tries to force us to get our staff to report how much time they spend with patients. And last year the figure was, we were supposed to hit 100%. Now we were doing all right. I think, whoops, I've gone too far. We hit 93%, but since July we're hitting 128%. So clearly the staff have got the message that we need to report on what we do, which is good. Again, this is just further examples of our dashboard. We have, like any machine, a community team or an inpatient unit, you've got to get people out to get people in. So, we actively measure flow. So if you're a community mental health team and you've got 10 new patients, then you really need to get discharge 10 people out to other care, because if you don't, you then start to get constipated. And, a lot of mental health teams, they do get constipated. And, I'm using that in a blocked sense, but it really is, it's just as important. So some people say, well, why did you send this person back to a GP? Like any business, we actually have to maintain flow. We can't take people into an inpatient ward. We can't take people into a community outpatient until we sort of move people on. Otherwise, you have waiting lists. We also measure this one here, the acuity. This is measured on the HONOS, and as you can see there, most of our patients are in the severe or moderately severe range. You'd actually have to wonder why you'd have 21 people in the subclinical range. But the reason for that is there are lots of people who remain in the mental health system, they remain under the Mental Health Act, and they are well, but if you take them off their mental health legislation, they'll stop their medication and then move up to the acute, very severe end. Moving on, again, this just gives you some idea of how our staff perform, and these are the various it's probably not going to be that interesting for you. Now, in last year's 2013 Partners in Recovery, you ranked third of the 7 issues were hospital experience and discharge. And these key priorities have been taken on board by the Mental Health Service. We're working much more to engage with people prior to discharge. We're working much more actively to get as many people as possible into safe accommodation, whether that's transitional or otherwise. We're doing that, I think, better. We're coordinating the aftercare, I think, better than we were, but you can tell us if we are. We're also listening to our consumers, so we've got an active, I don't know whether people know, but we've got 3 very large, consumer and carer groups that's been consolidated into a group of 15, which will advise Metro North with an independent chair who'll sit on our executive. And we've also looked very much at skills training. Now, in terms of the external review of the mental health service, the 2 or 3 things that were recommended, clearly, and this is where it fits very well with the Partners in Recovery, they've recommended that Metro North set up a step-up, step-down service. If you look at Victoria, we've got 3 catchment area mental health services. We actually need 3 step-up, step-down facilities, but if we get 1, it'll be a good start. And so, hopefully by the end of November, the money from Partners in Recovery that's gone to a consortium, including the Brisbane Housing Company, will come up with a proposal for us to take to our board to see whether the board will give us the money on the land to sort of go ahead. Another thing we're looking at is having a single number for Metro North Mental Health. Now, there's a statewide number called MH Call. So if you ring MH Call, it will direct you to a mental health service. And it was all designed and works very well if you've got a landline. The difficulty, and it works on the Pizza Hut technology, so I live on the south side, and if I ring from my home phone, it'll put me straight through to the local Pizza Hut. Unfortunately, mobile phone towers with Optus don't coincide with catchment areas, so it means if we go down the track of MH Call, and I don't know whether we will, we're either going to have one of those ones where you can go, if you live north of the river, press 1, if you live south of the river, press 2. And particularly, Redcliffe Caboolture falls into the Sunshine Coast Optus network. So I don't know what we do, but certainly by the end of next year, I'm hoping to have a single number. So if you're a mental health consumer in Metro North, there'll be a single number you ring to get through. The other one we're investigating, particularly up the northern end, is what's called a co-responder model. Essentially, a lot of people get brought up under the Mental Health Act by the police. Once you're in the emergency department, it ties up at least 3 hours of the consumer's time, as well as the police's time, as well as the mental health and the emergency department's time. And emergency departments aren't usually the best places for mental health patients, I'm sure you'd agree. But the co-responder model is about putting mental health staff, so when the police go out and they think there is a mental health concern, try to get a mental health person to go out with them in the car. It's not only probably going to be better for the mental health consumer, if indeed there is one, but it also may mean that the person can be diverted away from an emergency department presentation to either another, more appropriate government agency, or, they can be directed to a community mental health service. So those are the three things we're working on at the moment. And as you've heard, each one of them is at a different stage. We also had money last year for a project called Aqua, which was achieving quality across Metro North mental health. And one of the big things that we're still working on, but I think we're getting a lot better, is coordinating our beds. So one of the problems are that, we've got 179 acute beds. And I don't know, as I said to you earlier, flow is really important. So we know at Royal Brisbane and Prince Charles we need, on average, 5 discharges every day, because that's what's coming through the front door, and at Caboolture we need 4. And one of the things we find is that some days, some units are more busy than others. So Royal Brisbane might be fine today, but Caboolture might be flooded. So we're trying to set up systems whereby we plan ahead, how many discharges we're going to have for the week. But we're also setting up systems whereby Caboolture and I, as the ED, can actually have a look at where the beds are, so that if one unit's flooded, the other units can help out. Because I don't know what it's like in your organisations, but up until about 3 or 4 years ago, I would say the competition between Prince Charles and Royal Brisbane was intense. And, if Prince Charles had a bed and Royal Brisbane was full, or vice versa, you wouldn't necessarily help the other one out. And I think, these days it's much better, and I think the idea of everybody working together and helping people out is gradually dawning on our staff. I don't think it's perfect yet, but, that's what we're working on. We're also looking at crisis presentation plans, making sure that every mental health consumer who hits the mental health service, particularly if they come back on a regular basis, that there's a crisis plan in place to advise the person who's probably never seen them before the specifics of the case and how you can handle them. The Aqua project also has come up with Nothing About Me Without Me, so it's crucial to involve the consumers. All consumers that have a recovery plan. Recovery plans will commence as an inpatient, and we're trying to get golden rules such as involvement and making sure accommodation and finances are in order before the person leaves. We also estimate and set up an estimated discharge. So every week, if you're a psychiatrist, you plot out. So I'll just explain estimated date of discharge. Sounds weird, but I'll try and explain it as best I can. Most people, if you come into an inpatient unit, you haven't got any real idea how long they're going to be in hospital for. But usually by about day 7 to 10, you'll start to get some idea. And what you'll know is the person's starting to respond to medication, so they'll probably be out, like most people, within 12 to 14 days. Or then there are the ones at 10 days who are clearly not responding to, the medication, and they're going to be in long. But for those people who are going to leave within 12 to 14 days, you actually plan which day of the week they're going to go on. And so you plan what you don't want is 10 discharges on Wednesday, none on Thursday, and 3 on Friday. So you actually plan the week ahead. And so for each psychiatrist, we actually measure their estimated date of discharge. And some of them are actually getting getting it on board now that's actually important. And look, this is just some of our data. I'm going to sort of show you. It'll probably be boring, but I'll run through it fairly quickly. As you can see, recovery plans. One of the highlights of the life of a public mental health service is what's called the Australian Council on Healthcare Standards Accreditation. What happens usually just before accreditation, all the recovery plans go up, and as you can see afterwards, it goes down. Now, as you can see here, 2 of these services are approaching accreditation around that time. So that gives you some idea. In terms of estimated date of discharge, which I tried to explain before, we've gone in one of the units, well, this is from Metro North, about 38%. We're now up to about 68% some months. So, we are on a journey, but the services are responding. 1 to 7 day follow-up, which I've said to you before, normally stays around 60%. Some services go up and down, but most are around the 60%. So I'm relatively happy with that. This is the contact hours. This is the our services for our people in the community can justify 8 to 10 hours direct patient care a week. And when we started this, we were sitting at about 80%. We're now sort of, a year or 9 months later, we've certainly come up from, I'd say, an average of about low to 70s up to close to 100 in some cases. So, we're improving. Having people with a GP, we have a consistently very high measure of people with a recorded GP in SIMA. Now, let's keep moving. 1 minute, have I? Okay, I'll move very quickly. We're really keen to work with the NGO sector. I've said that before. Now, one of the things I really want to play you is this. Now, running a mental health service is it's a very complex issue, and it is so what I'm about to show you is called herding cats. I don't know whether you've ever seen it. But running a mental health service, this is my job. My job is to herd, and I'm not talking about mental health consumers here, I'm talking about our staff. Getting the different facilities, the different tribal leaders and stuff like that to work. Now, knowing Mark, it probably won't work now, but we'll see if it does. Hopefully it will.
This man right here is my great-grandfather. He's the first cat herder in our family.
Herding cats. Don't let anybody tell you it's easy.
Anybody can herd cattle. Holding together 10,000 half-wild short hairs, well, that's another thing altogether.
Being a cat herder is probably about the toughest thing I think I've ever done.
I got this one this morning, right here, and if you look at his face, it's just ripped to shreds, You
see the movies, you hear the stories, I'm living a dream. Not everyone can do what we do.
I wouldn't do nothing else.
It ain't an easy job, but when you bring a herd into town and you ain't lost a one of them, ain't a feeling like it in the world.
Thank you. Well, I'm happy to take questions.